Moving downstream to the nose and sinuses, this cartoon picture gives us a sense of where the sinuses sit in the face, and the kind of complexity of the drainage system. And what we can see from this is how at various junctures in the complex drainage system of the sinuses, that there are places where mucus plugs or inflammation can block drainage, similar to the idea of the inside of the ear behind the tympanic membrane, where things get stuck, and again, a little pus party might start up there and cause an infection. This picture also just reminds us as well that when we take a look into the patient's nose, and I would do that with the patient chin up a bit, press on the nose tip to flare the nostrils, look in there with your otoscope with a otoscope tip, and that gives you a view into the nasal cavity and a sense of what the mucosa looks like, as well as the turbinates, and sometimes even you can visualize polyps in there. Let's take a look at 3 cases. We've got a 20-year-old healthy male. He's been symptomatic for about 5 days. Probably has some complaint of runny nose, maybe a little bit of sneezing, feels a little congestion, hasn't felt great, might have had a fever for a couple of days, but is slowly improving. When I work over per diem at the College Health Center at another university, I'll often see these folks, and they might have missed a day of class, and that's their real reason for coming in. They just need a note, or they're just feeling miserable. And as a former professor of mine used to say, these are the folks that look more miserable than sick when we see them. The second patient is a 45-year-old male or female, doesn't matter, who has type 2 diabetes, has been symptomatic for 7 days, but has experienced what's called double sickening for the last couple of days. In other words, for about 4 or 5 days, his progress was similar to the first case, where he had cold symptoms, rhinorrhea, stuffy nose, maybe a little low-grade fever, and then seemed to be getting a little bit better. But then the last 2 days just got really sicker. Might have developed a low-grade fever, although remember, because of his diabetes status, that may not be as pronounced as some others, but generally has become sick and with pain for the last 2 days. The third case is a 19-year-old healthy female. She's been symptomatic with rhinorrhea, congestion, and now headache, off and on mild fever for 12 days, and her history is significant for having recently been treated for a strep throat with amoxicillin 2 weeks ago. I'll make a little side comment here that that you will see that amoxicillin isn't necessarily a first-line choice for a disease like strep throat. Reason being is penicillin, which is a narrow-spectrum antibiotic, is adequate for the treatment and eradication of strep, group A beta hemolytic strep. And when we use amoxicillin, since it has a broader spectrum, we often set up a patient for some resistance. So just a little side note about thinking about pharyngitis. And we'll talk about that a little bit later too. So these are our cases. Before I get into examining a patient in this kind of situation, I really want to ask myself a couple of essential questions. First of all, and foremost, I'm trying to tease out even just by their history, not particularly by exam findings, whether or not this is a cold or is a viral infection, or is it a bacterial sinusitis? And again, there are viral sinusitis as well, and that's still a sinusitis. And of course, there are chronic allergic kind of sinusitis as well. But I really want to try to discriminate between those two because I've got to make the choice of whether or not I'm going to go with any antibiotic treatment. As you know, in so many cases, the patient arrives with the expectation in hand that because they now have sinus pressure and discomfort, that they should have an antibiotic. And of course, they've been well trained over time, sometimes to ask for a Z-Pak, which we'll talk about in a little bit. But basically, they may want to have an antibiotic, but we've really got to decide whether or not that's appropriate. Again, as you know from talking a lot about antibiotics in your pharmacology course, setting them up for resistance is not a good plan, and we do not want to treat every cold, every viral cold, with an antibiotic for that reason. We do want to pay attention to thinking about differentials when we're walking in the room. As always, we're thinking, what's the worst case scenario here? What could I be seeing? What could the patient be thinking they have? But when I look at them, I say, wow, there's something else going on here. What don't I want to miss? And in that case, it would be things that would really point you towards probably a complication of a bacterial sinusitis, something that may be quite drastic, such as symptoms of meningitis, or things like a cranial nerve 6 impact, and the patient has, dysfunction on their cranial nerve exam, which you don't necessarily do with every case, of course. But these are the kinds of things that roll through your head. Has this gone into a more generalized infection? Is there an orbital cellulitis going on, which can happen as part of in extreme situations? So my red flags are things that basically are saying, the symptoms they're describing go beyond being contained in the sinuses, where there's pain, compression, inflammation, and so forth. Patients can have fever or not. That's not particularly a red flag for me. They can have fever with a viral infection or a cold. But things that tell me that there are neurologic changes are definitely a red flag, and deserve referral, as well as movement of the infection outside of the sinuses. I also want to consider whether or not this is a simple acute bacterial sinusitis or viral sinusitis versus something that's acute on chronic, which is a term that means that the person already has some kind of chronic sinusitis, which is not uncommon out there, particularly with folks who have exposure to smoke, themselves or others, folks who have chronic allergies, and or exposure to chemicals. In your book, it talks a lot about how people sometimes overuse the over-the-counter medications, such as the nasal sprays, which are vasoconstrictors. They then develop a rebound vasodilation if they stop using the medication. And then eventually there's actually changes to the structures in the nose, and some kind of ongoing dysfunction of that vasomotor response, so that they don't really respond to even the medication that they're using. So there's those chemical situations. There are situations such as pregnancy where we have this nasal congestion that's not infectious, and we may have on top of that an acute bacterial or viral sinusitis, rhinosinusitis. So these are the kinds of things that roll through my head as I go in and next go into an examination of the patient. What am I likely to find on exam with these patients? I'll focus my comments here on findings that are going to support the diagnosis of bacterial sinusitis, because that's where you end up in the antibiotic realm. And it's not to say that there aren't treatments, which we'll talk about in a minute, that will help any of these patients who are uncomfortable and miserable with their viral rhinosinusitis. But in the case of a bacterial infection, we will see evidence of fever. That may not be present at the time of our exam. It kind of can come and go, and that is still valid. Or they may have pseudo fever in that they have an elevated pulse rate, especially in the case of our fellow with diabetes. Their nasal mucosa, when you examine that, is going to look inflamed and red versus a pale appearance, which goes more with the chronic allergic sinusitis that we often see. There will be what's considered purulent nasal discharge. Now, there's a difference between purulent nasal discharge, which is basically pus, versus the kind of darkening of nasal discharge that occurs over time with a virus or a cold. So when we first have a cold, usually what comes out of our nose is pale or clear and fairly thin and runny. This gradually thickens over time in terms of the inflammatory response that responds to the virus, and over a period of time that becomes yellowish and then maybe a little greenish in appearance. But again, it is not thick and purulent with a foul odor to it. So there is a difference, and people get very excited when they see their children with runny noses and it looks green. Keep in mind too, based on the anatomy picture we looked at before, that children's sinuses are not very well developed, and so sinusitis in a child is kind of a funny diagnosis because a couple of those sinuses don't even develop until later, especially in a young child. But again, folks get excited about green snot, if you will. That's not necessarily what we're talking about here. We need purulence. There is usually some sinus tenderness. It can be over the maxillary sinuses unilaterally or bilaterally, or over the frontal is what we can usually palpate. The book does talk about transillumination and how insensitive that is. If we can transilluminate the sinuses, that's a pretty good sign that things are clear. You will remember from advanced assessment that we really don't even teach you how to do that anymore. It's not because so many times if the finding is that the sinuses don't transilluminate, which is a positive finding, this doesn't tell us much because many normal subjects have the same situation. So we don't really do that anymore. The patient may experience positional pain if you put them into a head down position, head back up, etc., or may not. That's kind of a plus minus. And of course, we note that there is no neurologic deficit and no apparent cellulitis of the face. And these are negative findings. And we want to kind of convince the reader that we've at least looked at the patient and that we haven't seen those. And certainly we want to consider any mention of those in terms of telling us that we're not dealing with a more extensive infection.